Today, I'm so pleased to have with me here, and again, I love having people right here in the studio. Dan, it's such a pleasure to have you here. Dr. Dan Kelly is a board-certified neurosurgeon. He's the director of one of four founders of the Pacific Neuroscience Institute, director of the Pacific Brain Tumor Center and Pacific Pituitary Disorder Center, and professor of neurosurgery at St. John's Cancer Institute at Providence St. John's Health Center. He also serves as president and CEO of PNI Foundation. Considered to be one of the top neurosurgeons in the U.S., he has been awarded the Southern California Super Doctor's Distinction 16 years in a row, a multiple recipient of the Patient's Choice Award. So he not only does good work, but the people he works with love him. Welcome, leaders. In a world constantly evolving, true leadership requires resilience, presence, vision, and a willingness to embrace challenge and change. I'm Dr. Stephen Sideroff, and this is Quantum Leadership Podcast, where we go beyond conventional leadership to explore the principles that connect mind, body, and organizational success. Dan, what a pleasure to have you here. Thank you.
Thanks, Stephen. Really happy to be here.
Great. Thank you. And let's just start with your story and path. There's so many different directions we can go, but in particular, helping to found the Pacific Neuroscience Institute, and how much of that journey you can share with us.
Sure. So I can go way back, but I went to college in California at Claremont McKenna College. Then I went to med school at GW on the East Coast, and ended up doing my training on the East Coast as well. Did my med school at Georgetown, training at GW. And then in 1993, I took a position at UCLA in the Division of Neurosurgery, and started with an interest there in brain tumors and pituitary tumors. Initially, I was down at Harbor UCLA predominantly, a level 1 trauma center, doing everything. But over time, I continued to do more and more work in the brain and pituitary tumor area. And then after about 12 years or so, I was getting a bit restless and looking at other options. And I heard about the John Wayne Cancer Institute, which is at St. John's Health Center in Santa Monica. And it looked like a really interesting opportunity, a very well-known cancer institute, but no neuroscience, no neuro-oncology. And so I took that. I decided to leave my faculty position. I was a tenured professor at that point, but decided to take a chance and go off and start something on my own. And really was essentially there by myself, but partnered very early on with Drs. Howard Krause and Chester Griffiths, a neuro-ophthalmologist and an ENT. And over time, and then I brought in a junior partner, Garni Barkadarian. And over time, we sort of grew the program. We developed, a program around pituitary surgery and brain tumor surgery. And after about 5 or 6 years, we began thinking about the idea of an institute model, because within the John Wayne Cancer Institute, it's all about cancer. And we were starting to bring in more colleagues helping treat strokes, hydrocephalus, facial pain. And a lot of the tumors that we treat, that I particularly treat, are benign tumors. They're not a cancer. A lot of the brain tumors we treat, such as meningiomas, pituitary adenomas, these are benign tumors. Still can be very challenging for people. But it became apparent that we could develop our own institute. And so with some support from the St. John's Health Center Foundation, we launched Pacific Neuroscience Institute. And the idea was sort of launched in 2015, and we formalized our relationship with the hospital and the system in 2017. And when we started, we had only 17 doctors in the medical group, and now we have about 40. So we've had a pretty big growth over 8 years, and we cover now not only at St. John's, we have 4 comprehensive stroke centers, we have 10 different centers of excellence, including things like stroke, hydrocephalus, facial pain, movement disorders. We created a brain health center, and we've created a psychedelics program. And so we've expanded dramatically, not only in the areas of neuroscience that we cover, but also geographically, and sort of helping Providence Health in the system here with their neuroscience portfolio. So that's sort of how that's the very abbreviated tale of how it started.
Well, I heard you say you were kind of itchy after 12 years. Was it what was it itchy for? Was it because you've gone from someone who does treating and who I guess was teaching at UCLA to now something a larger program where you're not just you're working with patients.
Right. So when we created PNI, I mean, the goal was for it to be a very academic center, not just clinical care. Many of us have come from the world of formal academics like UCLA. We call it privatedemics because it's sort of the best and perhaps the worst of both worlds.
Uh-huh.
I had a very good run at UCLA. I have tremendous respect for the University of California and the UC, but it also contains you in a way and uses you up in a way that can become a bit stifling. Mm-hmm. And I wanted to be a little bit freer, a little bit more entrepreneurial, and wanted to build something unique. And this was a really tantalizing opportunity at St. John's, and I jumped on it. So after being at UCLA for 14 years, I left. I mean, I started thinking about it at 12-year mark, and it took 2 years till I could reach escape velocity and go over to St. John's.
Beautiful, beautiful. Tell us a little bit about the obstacles that you faced, that you had to overcome in this process, and how it impacted you, perhaps from an emotional perspective and stress perspective.
So when I think back into those days now of 2005, 2007, it was very stressful in a way, but it was also very exciting. The idea of doing something new. And, my wife and I like Los Angeles. Our kids were young at the time. We didn't really want to leave. This was a really interesting opportunity. And I think the sort of the excitement to be able to create something new and be, kind of in charge of it was very exciting. And so when I look back at it now, in retrospect, it was the best move I ever made, for sure, leaving and coming over to St. John's, because it allowed this sort of creativity to blossom. And we had and still have good partners in St. John's and the St. John's Foundation and Providence. We have our challenges, but they've been really, really good partners in helping us grow. What initially started off as me just going over on my own, but then growing PNI into what it is today.
Mm-hmm. Did you feel at any point there that there was some risk you were taking?
Oh, yeah. I knew there was significant risk. And when I left, as a surgeon, you look at one metric of what you're doing is your volume. Okay. So when I left UCLA at that time, year 13, 14, I was probably doing 200 cases a year, mostly brain tumor type cases. When I left to go over to St. John's for the first year or so, my volume went below half of that for a while. Mm-hmm. And I knew it would take a little time. But at this point, I had been in the community for 14 years. People knew me. We had, published a lot. We've been training fellows. So I had a track record, and I had, great partners in, for example, Chester Griffiths and Howard Krause in sort of building this program around brain tumors and skull-based tumors and all that. So, yeah, it was risky, but it was never it wasn't to the point where I thought this isn't going to work. Mm-hmm. I think once we made the decision, we could see that it would work, and that we just had to keep pushing it forward.
Okay. So it was partly grounded in your history, in successful history, and knowing from that you'll be able to handle whatever came next. What were some of the obstacles that you had to overcome or deal with?
Well, I think, one of the obstacles, as I mentioned, in creating P&I was that we were in this, Cancer Institute model, and we were doing so many other things, and it just wasn't a good fit. And so, I started tinkering with the idea of a bigger institute, and one of the obstacles was, how do we fund this? How are we going to make this work? How are we going to bring in new faculty? And fortunately, the St. John's Health Center Foundation stepped in and gave us essentially a big loan, which we're still sort of paying off, but it was a big, gift that helped with directorships and research stipends so that we could create a sort of faculty environment where, much like what you would have at UCLA, where you have, I don't ever think of anything as protected time, but I know that's a term that's used, but that you would compensate individuals for developing a program like, the hydrocephalus program or the facial pain program, the multiple sclerosis program, where people get compensated for that programmatic development, and if they're involved in research, that as well. And so that has been a key to our success, that sort of support, that philanthropic support.
Nice. And so were you offering some kind of compensation for the people involved that went beyond their direct patient care to make it more inviting for them?
Absolutely. And I think that's the only way to do it. I mean, all of our clinicians are very busy, and you have to decide how to divide your time. And not everyone in the group has a research stipend or a directorship. There are some people who are just pure clinicians, but there's, a number of us who have both directorships and research stipends. And that's essential for them to feel like, they're compensated for this additional work, this sort of creative work and administrative work that's required to keep a program going forward in the right direction. Yeah.
And, I've been doing these interviews with people in different fields of endeavor, people in different kinds of technology fields, et cetera. So here you are the CEO, director of a professional organization. What might be different here than being the CEO of some other business like Best Buy, et cetera?
Well, for us, I think it all comes down to patient care. And I think, job number one for us is to take great care of our patients and keep providing innovative treatments for them. And that's sort of been our mantra, our motto, and to do it in a multidisciplinary fashion. I mean, when you think about the four founders of P&I, there's a neurosurgeon, there's a neuro-ophthalmologist, an ENT, and a neuro-oncologist. And that's sort of the multidisciplinary spirit. And I think that also breeds innovation and collaboration. I think that if you go into medicine, if your idea is you're going to get crazy rich, I mean, then you're probably in the wrong profession. That's not what this is about. I mean, we're I would say well paid for what we do, but it's about doing good things for the patients, and that's what makes, I think, the work so rewarding. Also, what makes our educational efforts so rewarding. We have fellowship training that goes on. We've trained more than more than a dozen clinical fellows. We've had over 50 international fellows that come in to observe in the clinic and in neurosurgery. We have a medical assistant training program. We do a lot of training with nurses. Our nurse practitioners do some training in that area. We put on courses like this coming weekend, if you're not busy, we have our Pacific Rim hands-on cadaveric microdissection course for skull-based surgery. And it's all about minimally invasive approaches. And we'll be doing a live surgery as part of that event. On Friday, we have a live surgery, a patient with a pituitary tumor that Dr. Griffiths and I will be operating on. And these are the sort of things that we that we do, that we try to not only provide great care, but we show people, we try to show people how to do it our way, and that we think is fairly effective most of the time. And so I think that's how it's different from a more, tech-based or corporate-based when you get out of this healthcare spectrum.
Yeah. And, one of the things that I've been emphasizing in my interviews and asking about is who the CEO considers as their constituency.
Mm-hmm.
So a lot of times it's usually the stockholders,
Right.
Right. But more and more in terms of what I've been emphasizing is to expand that constituency to include the customer, to include the employees, to include the community, to include the environment.
Yeah.
And what I'm hearing from you, because of how you're organized, because of what your work entails, the focus is on the quote-unquote customer, the patient. And so it's, in a sense, that's built into the system. And then the interdisciplinary nature of your organization also builds in relationships within the organization as well. So some of those aspects of what I consider good governance are built into the way your organization operates.
Yes, absolutely. I think that, again, patient care, patient outcomes is really job number one. But at the same time, we want to be innovative. We want to be involved in education. The other thing is we need to be profitable for the system to some degree. And so this is where there is, if you think about a gigantic healthcare system like Providence, and it's like many others, but they have 51 hospitals, they're a business, multi-billion-dollar business. Mm-hmm. We know, because we have something called the Joint Operating Committee, where we meet with we have partners within Providence. The P&I medical group faculty don't work for Providence, but we have a relationship with them, and we try to manage, the senior management in both groups have to work things out. And so this is always a challenge because there's a bit of a dichotomy where the things we do in the hospital, like brain tumor surgery, treating strokes and aneurysms, ENT surgery, those sorts of things, they tend to be very profitable. But in the outpatient clinics, mental health, brain health, those are big losers. And it's a challenge to make it all work, because arguably treating patients with dementia, multiple sclerosis, Parkinson's disease is just as important as treating a patient with a brain tumor. Mm-hmm. And so how do you hit that sweet spot where the system is saying, wow, you need to be doing more surgeries, and maybe we need to close some of your clinics because they're not profitable enough. And that's a real challenge. That's a real business issue that I think we're working through. We're working through it, and it's all the healthcare systems took a big hit during COVID, and there's still a lot of recovery going on from that. But it does force us to be efficient and to be productive to some degree. So it's a constant challenge. And I think one of the things, what is a differentiator about our medical group is that P&I also has the P&I Foundation. And so that 501c3 is the vehicle through which we have our directorships, our research stipends, and our marketing budget. And because we wanted to be able to control our messaging, we did not think that the system would do a good job with marketing. We're in a very competitive environment in Los Angeles, Cedars, UCLA, USC. And believe it or not, people shop for brain tumor care, for ENT, for their MS specialist, for their Parkinson's disease doctor. So you have to play that game in a big, competitive market that we're in. And the fact that we have our own 501c3 has been a complete game changer for us. We wouldn't be what we are. We'd just be another medical group if we didn't have that.
Mm. Okay. So now let's get down to brass tacks here. And you've indicated competing needs, competing goals between finance and patient care. What is it about Dan Kelly that makes you someone who's able to, manage these different requirements and needs as well as you do?
Yeah,
And
good question.
That's what our audience wants to know is how do we learn from your great experience here?
So I think a few things. You have to be somewhat of a risk taker, but not reckless. You have to be detail oriented, particularly as a surgeon, but in all these other administrative roles, you have to be detail oriented, and you have to be able to build relationships with people, and not be a hothead or someone who's morose all the time. You have to strike that balance because there's these constant challenges. And for me, the challenges, they can be, in the operating room, they can be with our leadership, they can be with some of our own faculty. And you have to be able to kind of manage an even keel. And I would say I've definitely matured. I'm not so young anymore. And I've learned along the way. But I think, those things, being somewhat of a risk taker, being disciplined, and building relationships that are really built on mutual respect and trying to understand the challenges the other individuals are going through. Those are kind of key, I think. On the sort of internal side, for me, I think regular exercise. I have a meditation practice for quite a few years now.
How much time do you spend on that?
Not a lot, 15, 20 minutes a day, but I do it every day.
Right.
And it really, I do it in the morning, right as I'm kind of getting up and getting going. And it's really, I always do it outside unless it's pouring rain, which isn't very often. It's very grounding. And I try to get enough sleep. I try to get 7 to 8 hours of sleep a night. I listen to a lot of music. I read a fair amount. And I don't, I try to, and some of this has changed over time. I didn't have a meditation practice when I was at UCLA. I wish I had. But I think those things are important. And I have a really, solid relationship with my family, with my wife and our two daughters who are now 27 years old. And that really helps. And I have a solid relationship with my two brothers. So those things really, really help. We're very close. And I feel just, very, very lucky, a lot of gratitude for that. Because a lot of people, you can choose your friends, but not your family. And I lucked out, and my mother and father have passed. My dad died he died of cancer when I was very young, when I was 8. And my mother died in 2015 when I was very, very close with her. So I think those sorts of things have helped me along the way, for sure.
So I'm curious how you handled your father's passing at such an early age, because that reflects a lot about how we deal with adversity.
Yeah. So when that happened, as I remember it, I was 8. I knew he was sick and he was coming in and out of the hospital. He actually had a form of lymphoma back then, which they had no treatment for. This was 1968. And he died within about 6 months. And I remember when, my mother and my grandmother, they told me that he had died. I was shocked. It was very hard to sort of fathom what it meant. And it's one of those events that I guess in some ways you never stop processing it, but it was such a long time ago now. And I think one of the great things about youth is, provided you have the proper sort of setting and support around you, you move on.
Right.
And that's what I did. And my mother and my two brothers, I have a great relationship with my brothers, but my oldest brother was a wild man in some ways, and loved to taunt the two younger brothers. And but then he became somewhat of a father figure in a way. He kind of did what he had to do, and that was an important thing.
What was the age difference?
7 years.
Okay.
And 4 years with my other brother. So
Right.
Pat is 7 years older. Tim is 4 years older.
Okay. Yeah.
I'm the youngest.
It served you in that instance.
It did.
Yeah. You mentioned risk-taking.
Mm-hmm.
Can you give an example of where that's appropriate, or how it was appropriate, and how you managed it?
Well, I think leaving UCLA and jumping off into a private world, that was probably, from a professional standpoint, that was the biggest risk I ever took. I think a lot of people, when they leave academics, they never come back, but that's exactly what I didn't do. We built, in my opinion, a better academic environment, and we have, we do so many clinical trials, and we have so many peer-reviewed publications, and we have in this environment, I think we've, it's really developed into a beautiful kind of academic setting in the private practice world, and educationally as well, in terms of all the training, fellowship training that we do. So that was pretty risky, and it was I would say, a really good move. I guess another one could be considered creating a program around psychedelics, which I had psychedelic experiences when I was young, when I was in college at Claremont, that were highly impactful. I had a couple unpleasant trips as well, but I had mostly really impactful ones in a good way. Mm-hmm. And that never left me. And I think it's part of the reason I went into the neurosciences, my, intrigue with the mind and the brain, and ultimately toward neurosurgery in a way. But when I started hearing about psychedelics again, because I had been completely oblivious to this sort of renaissance that had been going on since around the year 2000, or even a little before that. And it wasn't until Michael Pollan's book came out in 2018 that I kind of woke up and saw that this was going on. And I remembered my experiences, which, recreational use in a way, but still very impactful experiences of how you look at the world and that sort of thing. And I thought, wow, there's a huge potential here for mental health and the neurosciences, for things like pain, dementia, other things, let alone conditions like depression, anxiety, addiction, PTSD. And so at that moment, it was sort of a revelation. I thought, wow, we have to create a program around this, or what kind of neuroscience center are we if we don't do that? And so I sort of dove into that and very quickly worked with the foundation, and we recruited Dr. Keith Heinzerling, who is now the program director. And but when I first did this and started talking to people about it, they would look at me as if I were crazy. And what are you talking about? Psychedelics. And so I think that was a risk that paid off. And really, it's a testament to all of these people that have sort of resurrected psychedelics, of the risks that they took. Like Rick Doblin and many others at MAPS over the years, who have taken a huge risk and lots of time and effort to try to help us achieve and determine if there is really potential of psychedelics for mental health disorders. So those were probably two of the risks.
And that is something that takes some bravery to do. Looking at the history, where when it first came on the scene back in the 50s and 60s, there was this huge potential, but at the same time, it got a bad name and went underground for so many years. So yes. I think It's people like you, organizations like yours that are saying, wait a second, there's something of value here that we'd be crazy not to research appropriately and uncover its deeper value, which I agree it has huge potential. So congratulations on taking that particular risk and moving forward with that.
Yeah, we'll see where it goes, but it's very exciting work. I think there's a huge amount of potential. I guess I would say one other thing about risk, and I kind of forget about it in a way, but it's the risk of what we do with our patients in the operating room every week. The brain tumor surgery work that I do, we're constantly around, critical blood vessels, the carotid arteries, the optic nerves, the pituitary gland, what we call eloquent cortex, speech and motor areas, those sorts of things, visual processing areas. And that's a different sort of risk. And it's, I think what's beat into you as a surgeon is this concept of complication avoidance and maximal safe removal of, say, a tumor. And I think that is all about having a very real understanding of what the risks are and the consequences if you stray or you injure something, the consequences to the patient. And as surgeons, we've all had bad complications, and those really stay with you, and you hopefully learn from that and become a better surgeon in the process. And so that's another sort of daily risk that you have to deal with.
Yeah, when you were talking about the program happening this coming week, and you are going to be doing an operation in full view of everybody, I immediately went to, wow, Dan, that takes a lot of courage and confidence that you can do that and know that your best will be good.
Sure.
To do it in front of so many people. I think that's tremendous, both courage and confidence.
Well, I think you want your surgeon to be courageous and confident, but not reckless.
Yeah.
And I think that's what makes a really good surgeon, is sort of knowing the limits, understanding the tolerance of the tissues, what the patient wants, the anatomical realities. All of this stuff goes into sort of the in the moment thinking in a given surgery, and the planning of the surgery too. And so, fortunately, I've been doing this for quite a while, since I finished my training. I think 32 years. So it's a pretty long track record. And so I think we do have things to teach to the younger generation of how to optimize an operation and avoid problems.
Yeah. Yeah.
So hopefully it will go smoothly on Friday.
I was fortunate to observe one brain operation like that done by Penfield.
Oh my. Wow.
At the Royal Victoria Hospital when I was a professor at McGill University.
Oh my gosh. That is so cool.
I know.
Yeah.
And the theater was really one of these classic old theaters,
yes, with
circular,
very steep and looking down.
Yes.
And yes. Well, we still use the Penfield dissector.
Oh, wow.
Yeah. The Penfield 1 and the Penfield 3. Those are used all the time in neurosurgery. Yes.
Beautiful. Let's go back to one of the other things you mentioned, which is relationship building.
Yes.
And I'd like you to talk a little bit about that. Of course, again, much of it is with professionals, but you have an entire organization that you are the head of. Can you talk a little bit more about relationship building and how important that is? And again, if you can maybe identify some of the qualities you have that allow you to do such a good job at that.
Yeah. I would start with the patients and their families. When I see a patient with a newly diagnosed brain tumor, I spend a fair amount of time with them tell them what their options are. We discuss whether or not they need surgery or not. The happiest patients are the ones say, we don't need to operate on this now. Let's keep an eye on it. Let's do another scan in 6 months or a year. But when you do recommend surgery, being very clear on what the goals are, what the risks are, and just being with them, to sort of make sure that they get a feeling of trust about you and provide them expectations. One of the things we did during the pandemic, and we were already doing it, we encouraged people to get out of the hospital soon. So most of our brain tumor patients, pituitary patients, they leave the hospital the next day. So they're in the hospital for 24 hours.
Wow.
Some of the brain tumor patients, some of the other, they'll stay a day or two or sometimes 3, but that's sort of, expectation management. You're going to be much better off at home. You don't want to be in the hospital. And we do that routinely now. So that's one sort of level of relationship. The other is with...
Before you move on,
yes.
let me check in with you on this, because you're frequently dealing with people with very serious conditions, life-threatening conditions.
Yes.
How do you personally handle that emotionally in that interface where people are maybe very emotional about the news, fearful?
Yeah.
And how do you handle that?
You do have to sort of internalize it, but there are times when, for example, I'm seeing a young adult woman like my daughters with something like that, and it always catches me because you worry and you see that and you see what they're going through, and it's very, jarring in a way. But you have to maintain that sense of calm and assurance to them that we're going to do the best we can. There's some cases, fortunately, probably the majority of what I do are, quote, benign tumors, but I deal with a lot of malignant tumors that are, where people will have a survival, if they're lucky, of 1 to 2 years, maybe 3 years. And that's very hard discussion. And it's just something that comes with the territory. And, I suppose on one level you go, I'm just, you feel really sorry for the person, you do everything you can, and you have to keep going. And I think if you didn't do that, you wouldn't be able to practice, because you would take every one of these, new diagnoses so hard on yourself that you would become almost paralyzed in a way. And I think you have to have a way to sort of rise above it. But those thoughts are always there. They're in the background, and sometimes they're a little louder than others, depending upon the patient and the day.
Yeah. So I know, as a psychologist, taking this all in, that very early on in my career, I had to find the right balance. And then I personally developed a ritual at the end of my day, every day, where I would just imagine being under a waterfall and having that waterfall just take away all of those emotions from the day.
I like that.
And that really worked for me. So, but it's really tough. And people, they have emotional struggles, but not typically life and death.
Right. No, it's a daily challenge for these conditions. And I like the waterfall approach.
Yeah.
So I would say then, for example, in the operating room, working with the team, the scrub nurses, the circulating nurses, the people that work on our what we call navigation, that are doing electrical monitoring, the anesthesiologist.
How big a team usually?
Well, on a given case, there's an anesthesiologist, there's a circulating nurse, there's a scrub nurse, there's someone managing the navigation, there's someone doing electrical monitoring. There's, me and another co-surgeon, our fellow, or sometimes if I'm doing an endonasal approach to the nose, Dr. Griffiths or Dr. Young. So it's a lot of people.
Right.
And sometimes there's people observing. They're watching. And, you want to have an environment in the room that's supportive and not not intimidating. And back in the day, as you probably well remember, surgeons had, and some still have, a reputation of being, prima donnas, holier than thou, not very nice to the staff. And that's not at all how we operate, literally or figuratively. And it's a very nice environment. And I think our team we're really lucky to have a great team. We have obviously a group of anesthesiologists, but we have our sort of circulating and our scrub nurses are generally excellent. And we really like working with them. And it's a nice environment, which is what you want. You want everyone in the room for something like that, for a big invasive procedure. You want everyone to be sort of calm and in the moment. And that's what we try to do.
What do you do specifically to engender that atmosphere?
Say good morning to people. How you doing? We make jokes. We don't listen to music that much. I know in a lot of ORs there's a lot of music. We don't do that too often. I think when things aren't going smoothly, you try not to lose your cool, lose your composure, those sorts of things. But it's a matter of more or less just being nice to people, and acknowledging them and that sort of thing. I think it's really pretty simple interactions in a way. With regards to the, dealing with, my co-founders in the group, we're obviously very close. We've spent a lot of time together over the years. We give each other a lot of, hard time. And a lot of the more senior faculty, and there's just a lot of back and forth in a good way. I think when we deal with the sort of administrative side of things with Providence, they're really a lot of great people. And even though we don't agree with what they're doing, they're generally sort of following what they have to do. And you really need to find a way to work with them. And I think having an attitude of just trying to see what they're dealing with and trying to figure it out is the way forward. And because, those kinds of relationships can really be important. And I think building relationships where people trust you and they know, you've got their interests in mind, and vice versa, you're going to get a lot more accomplished, I would say.
I'm hearing a little bit of empathy for where they're coming from, being able to be flexible and actually put yourself in their shoes is part of how you maybe deal with approaches that are not the way you would do it, but you have to work with them. So that's how you get to a place of acceptance.
Yes, I would say you said it better than I did. I think empathy is key. Do I occasionally get frustrated, lose my temper once in a while? I've never been much of a hothead, but occasionally I you hit your limit where you go, what is going on here? And you really, and I think at some point, you can't be so soft and empathetic that you're getting kind of pushed around.
Right.
And I think in some ways it's important for people to know that there is a limit, and that, if things don't come up to where you expect them to be, don't go where they should be going, there needs to be, some consequences. And I think that's an important side to it. That's sort of the yin and the yang, or the balance that you have to strike as a leader to, make sure that people are doing what they should be doing in a way, but not be too overbearing.
Mm-hmm. So I think that's a very important aspect of leadership, is that balance, so to speak. Do you have an example of where you were challenged and sort of where to come down in terms of that balance?
I don't know if I want to give you a specific example. They're too particular.
If we could be anonymous about it, maybe.
Well, I mean, I think that I'm not sure I have a really good. I mean, the things where I would talk about it would be more sort of revealing, and that
Okay.
than I probably should be.
Okay.
You know,
I got it. Yeah.
wait, I may have to edit that part out.
Right.
But we have some things going on now that are really challenging that we're trying to work through that are I don't know what the outcome's going to be, and trying to really take in all perspectives and be somewhat patient, but I'm pretty impatient. And some things, when things drag on for too long, that bothers me to a point where you go, why is this taking so long? And I think a big organization like Providence, which is very layered and now very cash strapped and personnel strapped, it takes a lot of time for things to happen that you would think could move along more quickly. So those are some real frustrations. But yeah,
Well, in those moments, in these moments, where you're in this trying to have patience, but impatient and wanting things to happen, and maybe because of the bureaucracy, it's not happening as fast as you would like. What is it about Dan that you fall back on as your rock, your ground in those situations?
I would say that I have so many things going on that I can easily get directed into other, another endeavor or another problem. We have a chief administrative officer, Chris, who's just phenomenal, and we're dealing with, between the P&I Medical Group and the foundation, we have innumerable issues that we have to deal with. Many really good things and then a bunch of challenges. And so, as it relates to work, we do what we can up to a point, and then we have to sit and we have to wait. And there's some certain things you just go, okay, we just have to wait. Let's see what happens. And so I think part of it is you just have to go. You can only do so much. You can't. I'm just one person in one. In the grand scheme of thing, one person in one medical group in a hospital system of over 50 hospitals. And there's a lot of complex relationships. You can only do so much. And then I think you have to go back to these things that ground you to, go for a run, listen to some music, take a swim, meditate, spend time with your family. You can't just let it hang there.
Yeah. Well, I think we're talking about one of the biggest issues of being a leader is that, and we could take just what we're talking about right now, where you have so many things going on, and then you have something over here that doesn't have an immediate resolution. And so from an internal perspective, where you have to be focused in everything that you're doing, how do you put something like that up on a shelf, or how do you deal with something that's unfinished, that's weighing heavily in one respect or another, but now you have all these things to go to, and there's no quick, easy solution?
Well, I think that part of that is just aging and experience, where you come to realize and accept there's only so much you can do, and focus on the things that you can change, and don't spend a lot of time being upset about it and worrying about it. Do everything you can to get it as far along, and then you just say, okay, let's see how this is going to go. And I see that, I used to get much more upset about those things, and I see it in some of our junior faculty. Mm-hmm. And I try to say, just calm down. It's going to be okay. This is going to take time. You just have to go through this process. And I think it's a part of maturity and experience of knowing how far you can or should push something. Because after a while, it's more about you pushing, and it becomes internally a problem.
Right.
It doesn't help you, and you may lose sleep over it and get upset about it. And it's just not, it's probably not very productive. Mm. But that's not to say you shouldn't be thinking that your problem solving should always be going, okay, here's the issue. How can we get around that? And I do a lot of that. Okay, if we can't get in here, can we go around this way? Or can we go this way? And that's also, that's part of like the surgical strategy that we use. So it's applicable to solving, I would say, problem solving on this bigger level of a big sort of bureaucratic administrative matrix of how do you move the needle without, blowing yourself up in the process, or your partners, or something like that. You know, so you just, I think it part of it is really maturity and experience.
Well, we're also getting in the realm of innovation and creativity, thinking outside the box. And how would you characterize those qualities of Dan in terms of your approach?
I would say that I'm a fairly creative person, and it's in a sort of different way. I like to, when it comes to surgery, for example, we've been really leaders, some of the leaders, I would say, nationally and internationally over the years, in minimally invasive approaches to remove brain tumors. And we've pushed that, and there's a sort of a collective group. It's not things that I just came up with on my own, but there's things that we've perfected over time, and we've published a lot on it, and we teach about it. And I think that sort of innovation has been really part of the fun of being a neurosurgeon in this era, with great technology and really great tools, and the micro instruments, and that has been really fun. There's been a lot of innovation. I think, I would say that P&I is a very innovative model. There's nothing like it in the country. There's really not. We're a pretty big, successful model. This sort of privatemic entity that has a big national standing on many levels across all these different neuroscience areas, and so sort of building out that model, this neuroscience umbrella with centers of excellence and collaboration, that I think has been sort of our key story of what we've done. And like I said, having the foundation was a game changer, and I give all credit to that to our attorney, who is brilliant, and said, if you guys want to have a ability to do research and education, you have to have your own 501c3. Otherwise, it will just get buried. It'll be forgotten. And that was a complete game changer. So from a structural standpoint, that's been hugely innovative and critical.
Yeah. So to some degree, I'm hearing that as you take the different levels of challenge in your career, the challenges present you with opportunities to be creative and to be innovative. In other words, so if I'm going to step from here to here, I have to figure out something new because I'm forming a new kind of organization. Yes. And so I have to use innovative ways of making it a success. So creativity, innovation almost built into the process there.
I would say so. Absolutely. You've got to be looking at fresh ideas and talking to people and listening to people. And it hopefully it breeds good innovative concepts. I think the other challenge is neuroscience is such a gigantic term, neuroscience and mental health, and we have a big brain health center now as well, as you know, and these are huge, broad swaths of the medical universe, and it's hard to stay up on, let alone one subspecialty, but to do it in 10 or 11 or 12, and so you have to choose people that are going to be leaders in the field that want to advance things, say in movement disorders, multiple sclerosis. We have a great cochlear implant program led by Dr. Courtney Volker, and she's an otologist, neuro-otologist, and there's a beautiful synergy between hearing and dementia. That is, if you lose your hearing and you already have a propensity for mild cognitive impairment, it's one of the biggest modifiable risk factors for dementia is to fix your hearing, either with a hearing aid or a cochlear implant. And so those sort of interfaces, which I didn't know about really until, getting into this and hearing from my colleagues. So you have to be watching for those things and sort of choose the areas that I think, excite you and look tantalizing, because you can't do it all.
Right.
Obviously.
Right.
And we're not a UC. We're not part of the University of California. We're not some big academic institute that has billions of dollars behind it. Right. So we have to choose our innovative avenues pretty carefully.
Right. Well, you seem to have been doing a great job of making those choices and have gotten your organization to a very, very successful place. As we're getting close to the end of our conversation here, I'd like for you to kind of identify what other aspects of you as a leader has contributed to that success.
That's a good question. Well, I may talk about this now because it's relevant, is sort of passing the baton in the transition. I turned 65 a few months ago, and I still have a lot of energy and things I want to do. But I also, some of the stuff that I do is not as fun as it used to be. And I think watching other institutions flail during a transition process is highly illuminating. And I can tell you that the P&I founders, we want it to continue and to continue to grow. And so we're very much thinking about this transition process over the next, few years, and how it can continue to thrive and to the next decade. Because we were almost through. This summer will be 10 years since we created P&I and 8 years since we joined Providence. So it's really sort of our 10-year, it's the end of a decade. And we hope to be going strong over the next decade. Whether I'll still be a part of it, I don't know. But I think if you create something that has value and worth to the community and the people in the entity, you want it to keep going. And so we very much want to do that. And so I give a fair amount of thought to that right now, and to do it in a way that is logical and thoughtful and with hopefully a high chance of success.
Mm-hmm. Yeah. So always looking ahead.
Yes.
Not right here, right now, but what's going to happen over the next few years.
Right. I think you have to sort of be in the moment for a lot of things, but you do have to do some succession planning for an organization like this. And it will go a long ways towards building the success. So, of course, I've never done that before, but I can imagine, and I've seen other examples where it didn't go so well, that I think that's important. There's a tendency, I think, in some organizations in some medical organizations for people not to be willing to let go. And I've certainly seen this with a lot of surgeons who kept operating way beyond the time that they should have, and even into their 80s, which I think is probably not a great idea. I do not intend to be operating when I'm 80. And I think people need to know when it's okay to really pass the baton.
Good advice. Good advice. And then finally, can you share some of what you love most about being in this position of leadership?
I like the idea of being a thought leader, of being able to help the group grow and innovate. I like to see the junior faculty grow and thrive. I really enjoy our fellowship training. I stay in contact with a lot of our fellows that are out in the world now, doing great things wherever they're practicing. That's always makes you feel good when your trainees, your fellows get back to you, or they send questions about a case. How would you do this? That sort of thing is always, it's nice to connect with them. I think just seeing it grow into something, sometimes I can't believe it. I thought I never, when I left UCLA and I came to St. John's, to the John Wayne Cancer Institute, which is what it was called then, I never envisioned that this would happen. I did not come to St. John's thinking I'm going to build Pacific Neuroscience Institute. That was an evolution of thought that occurred over, 5 or 6 years. And so to see where it is now is really gratifying, because I think we've helped a lot of people patient-wise. We've helped the community with a lot of the educational stuff we've done. We've helped bring some prominence, some notoriety to St. John's and to Providence, because they were not on the map at all in the neurosciences until we did what we've done. And so that's very gratifying, and it's just nice to see.
Right. And it's also good for the audience to hear that where you've wound up was not necessarily your vision when you started on this path, this journey, but that each step of the way sort of gave you a new perspective from which to launch to the next level.
Exactly. I did not have this dreamed up when I left, and not at all. It's almost as if I stumbled my way into this pathway over time. And I say, certain things also are true, that there's a certain amount of luck to these things that I think you have to acknowledge, that timing is everything, as they say. The right people that wanted to help us at the St. John's Foundation, having an amazing attorney, having great partners, the founders of the group. A lot of things just sort of came together, and that was sort of a big recipe for success.
Well, here's the one area where I will disagree with you, because I think we make the luck we get. I think it's taking the steps, taking the calculated risks, putting ourselves in different positions, make us more available for new opportunities. And the timing and the synchronicity, I would say, are consequences of the energy we put out. And so I'm very appreciative of the energy, Dan, that you've put out, because we can see the beautiful results. So thank you for being the leader that you are, and continued success on the trajectory that you're on. And thank you again for being a guest at Quantum Leadership Podcast.
Thanks, Stephen. It's been a real pleasure. And I think this is a great podcast that you've put together. I like the format, and it's a really nice thing. Thank you.
Well, thank you too. And thank you for joining me on the Quantum Leadership Podcast, everybody. I hope today's conversation has inspired you to think bigger, lead more authentically, and take steady progress and steps meaningful for you in your own journey and path. If you know a leader who would benefit from these insights, please share this episode with them. And thank you again for listening. Thank you, everybody, for joining me on this Quantum Leadership podcast. I hope today's conversation has inspired you to think bigger, lead more authentically, and take steps toward meaningful change. If you've enjoyed this episode, please share it with others and make sure you subscribe and go to my website, drstephensideroff.com. Thank you again.